Welcome to the Scientific Dose. Today, we're decoding the ultimate diagnostic toolkit, cardiac biomarkers. We're going to look at the invisible molecules floating through our bloodstream that act like cellular alarm bells. If you've ever wondered how an ER doctor can take just one look at a blood test and instantly know if someone is having a heart attack, heart failure, or a massive blood clot, well, this explainer is absolutely for you. We're going to cover every single detail, missing absolutely no information, to give you a complete foundational understanding of this totally fascinating physiological toolkit.
Think of this explainer as a medical detective's map. We're going to break down a massive amount of dense clinical data into 6 systematic chapters. Basics of clinical enzymology, the energy enzyme creatine kinase, MI markers, heart failure, thrombosis and D-dimer, and finally, we'll test our knowledge with a real clinical case diagnosis.
All right, let's jump right into Section 1, Basics of Clinical Enzymology.
So before we get into the heavy hitters, let's establish some ground rules about how and why enzymes appear in our blood in the first place. What actually is a biomarker? Simply put, it's a measurable biological indicator. It reflects normal biological processes, pathological disease processes, or how your body is responding to a treatment. The key here is that it has to be objectively measured, highly quantifiable, and clinically relevant. For example, when we measure a protein called troponin in the blood, it acts as a direct, highly objective biomarker for myocardial or heart muscle injury. Now, there's a really fascinating difference between the two main types of enzymes floating around in your plasma. We've got plasma-derived enzymes and cell-derived enzymes. Plasma-derived enzymes, like your clotting factors, are actively secreted right into the blood because that's where they do their job. Normally, they're present at really high levels, but in a disease state, like liver failure, those levels actually go down. On the flip side, we have cell-derived enzymes. These guys are meant to stay locked securely inside your cells. In healthy blood, their levels are basically zero. So when those levels suddenly spike in the blood, that is a massive red flag indicating cellular necrosis or damage. In cardiac diagnostics, we're almost entirely focused on these cell-derived enzymes escaping into the bloodstream.
So you might be wondering, how do these cell-derived enzymes actually flood the system to begin with? Well, it really comes down to 3 main mechanisms. First up is increased cellular release. This happens when tissue is inflamed or dying, causing the cell membrane to literally rupture and leak its contents. Second is decreased excretion. If your kidneys are failing, for instance, enzymes like amylase just build up in the blood because they aren't being cleared out. And third is enzyme induction. This is when your body actually ramps up the production of certain enzymes in response to severe stress, drugs, or toxins. Understanding these 3 mechanisms really anchors the entire logic of diagnostic enzymology.
Moving right along to Section 2, the energy enzyme, creatine kinase.
Creatine kinase, or just CK for short, is the absolute key enzyme responsible for energy metabolism in your muscle tissue. But it isn't just one single molecule. It comes in 3 distinct flavors or isoforms depending on the tissue. CKBB is found in the brain and smooth muscle. It's totally absent in normal blood, but it spikes during a stroke. Then there's CKMM. This is the dominant form, making up 95 to 100% of the CK in a healthy person's blood, and it'll shoot up during skeletal muscle trauma. But the one we really care about for the heart is CKMB. Normally, it makes up less than 6% of total CK. When the heart muscle is injured, CKMB floods the system. Here's the crucial takeaway. If a patient's CKMB2 to CKMB1 ratio is greater than 1.5, it is a huge indicator of an early heart attack.
Let's track the exact timeline, or the kinetics, of CKMB right after a cardiac injury. It starts to rise about 3 to 6 hours after the injury occurs. It peaks pretty quickly, hitting its highest concentration between 10 to 24 hours. And here is the most important clinical feature to remember. It returns to baseline normal levels by about 36 to 72 hours. Why does that fast drop matter so much? Because if a patient has a second heart attack, a reinfarction, just a few days later, those CKMB levels will clearly spike again. Its quick reset makes it the absolute perfect tool for detecting early reinfarction.
Next up, Section 3, MI markers. We're looking at troponin, myoglobin, and AST.
All right, let's stack these markers up against each other, comparing some of the older historical ones with our modern gold standards. Myoglobin is the absolute fastest to rise, kicking in within 1 to 3 hours, but its specificity is low, and its normal value has to be strictly under 90 nanograms per milliliter. CKMB, like we just discussed, rises in 3 to 6 hours, with a strict normal of under 10. But look closely at cardiac troponin I, or cTnI. It also rises in 3 to 6 hours, but it stays elevated for a massive 7 to 10 days, with a virtually zero normal value of less than 0.04 nanograms per milliliter. And AST? That's an older historical marker. It rises late, around 6 to 10 hours, has very low specificity, and normally sits between 10 to 40 units per liter.
When you actually plot these kinetic curves out, it is pretty incredible to see exactly how the heart sends out its SOS signals over time. Check out the green line. That's myoglobin. It spikes almost immediately, but fades incredibly fast. It's completely gone by 24 hours. The blue line is our middle wave, CKMB, cresting around a day and fading by day 3. But look at the red line, troponin. It rises early, but stays elevated for up to 14 days. This gives doctors a massive, highly specific diagnostic window to detect heart damage long after the initial event took place.
But what literally is troponin? On a molecular level, it's a regulatory protein complex that actually controls heart muscle contraction. And it's made up of 3 distinct subunits. You have cTnI, the inhibitory subunit that keeps the muscle relaxed. You have cTnT, which acts as the anchor binding the complex to tropomyosin. And finally, tNC, the calcium binding subunit that triggers the actual muscle contraction. When calcium floods the cell, it binds to tNC, changing the shape of the whole complex and allowing the muscle fibers to pull against each other. Here's the kicker clinically. tNI and tNT have forms that are 100% unique to the heart. tNC doesn't. And that is exactly why only cTnI and cTnT are used as our specific cardiac biomarkers.
And this brings us to exactly why troponin is the undisputed gold standard today. It possesses incredibly high sensitivity, high specificity, and as we saw in the graph, a prolonged diagnostic window. Compare that to myoglobin. Sure, myoglobin is the earliest marker to rise, but it is deeply limited because it's just not cardiac specific. It'll spike from simple skeletal muscle trauma or even if a patient has renal failure or severe burns. And AST? While it used to be a go-to back in the day, we now know it's found in the liver, the brain, and the kidneys. Today, AST's diagnostic value for a heart attack is entirely historical. It's been completely replaced by the precision of troponin.
All right, shifting gears now to Section 4, heart failure and natriuretic peptides.
We're pivoting now from markers of tissue death to markers of stretch, fluid, and pressure. When a heart is failing, it struggles to pump. This causes blood volume to back up and literally stretch the walls of the heart. In response, the heart secretes a family of hormones called natriuretic peptides to protect itself. There are 3 main players here. ANP is released from the upper chambers, the atria, in response to volume overload. BNP is released from the lower, much more powerful pumping chambers, the ventricles, and this is our primary marker for heart failure. Finally, CNP is released from the blood vessel walls, the endothelium, to cause vasodilation, though it doesn't have a major role in cardiac diagnostics. Ultimately, these peptides are desperately trying to save the failing heart by forcing the kidneys to excrete sodium and water to drop the blood pressure.
Imagine a physiological tug-of-war happening right inside a failing heart. On one side, you've got the RAS system and the sympathetic nervous system, or SNS. They are actively trying to constrict blood vessels and retain water, which is honestly terrible for a heart that's already failing. On the other side, acting as the physiological hero, is BNP. BNP actively blocks and downregulates the RAS and sympathetic systems. It forces vasodilation, it suppresses renin and aldosterone, and it aggressively lowers both blood volume and pressure.
In the lab, we're looking at either BNP or its inactive cleavage byproduct NT-proBNP. You absolutely need to lock in these exact thresholds. BNP is biologically active with a super short half-life of about 20 minutes. NT-proBNP is inactive but much more stable, lasting up to 2 hours. Now, if a patient comes into the ER gasping for air, we check these levels immediately. If their BNP is strictly less than 100 picograms per milliliter, we can safely rule out heart failure. But if that BNP is greater than 400 picograms per milliliter, it definitively rules in heart failure. These specific numbers are what guide life-saving therapy decisions right there on the spot.
Moving on to Section 5, thrombosis and D-dimer.
When we're not looking at the actual heart muscle, we're looking for blood clotting within the vessels. And D-dimer is a fascinating protein fragment that acts as the ultimate coagulation marker. It's only created through a very specific 5-step physiological sequence. Step 1, a blood vessel is injured, activating the coagulation cascade. Step 2, thrombin converts fibrinogen into sticky fibrin monomers. Step 3, factor 13A comes in and weaves these threads together into a stable, cross-linked fibrin clot. Step 4, the body realizes it eventually needs to clear that clot, so an enzyme called plasmin begins to chop up and degrade the cross-linked fibrin.
And finally, step 5, this breakdown produces fibrin degradation products, specifically D-dimer. Therefore, D-dimer fundamentally proves that a clot was not only formed, but is actively being broken down in the body.
And here is the absolutely vital clinical takeaway for D-dimer. It is a highly sensitive rule-out test. A normal D-dimer is strictly under 500 nanograms per milliliter. If a patient has a normal D-dimer, its high negative predictive value means we can confidently exclude life-threatening conditions like a deep vein thrombosis or a pulmonary embolism. However, a high D-dimer cannot confirm a clot. Why? Because D-dimer levels also spike naturally during pregnancy, surgery, trauma, and severe inflammation. So a negative result means you're safe, but a positive result just means you need immediate imaging.
Let's put it all together in Section 6, Clinical Case Diagnosis. Picture this. You're presented with a 68-year-old male who arrives at the emergency room with acute dyspnea, severe shortness of breath, chest pain, crackles in his lungs, and a visibly swollen left calf. We quickly draw his blood, run the full cardiac panel, and the results are honestly shocking. Troponin I is sitting at 0.85. Remember, normal is strictly less than 0.04. CK-MB is at 28, nearly 6 times the normal limit. His BNP is screaming at 1,420, well past that 400 rule-in threshold, and his NT-proBNP is a staggering 6,800. Finally, his D-dimer is at 4.8 milligrams per milliliter, almost 10 times the normal cutoff. Every single marker we've discussed today is blaring a massive physiological alarm.
So let's synthesize this data. We're looking at a dramatic dual diagnosis here. The massive BNP levels definitively confirm severe, decompensated heart failure. His heart is literally drowning in fluid. That sky-high D-dimer, paired perfectly with his swollen calf and shortness of breath, highly suggests a massive deep vein thrombosis that has broken off into a pulmonary embolism. And what about the troponin and CK-MB? Well, they're elevated not from a primary blocked artery, but because the extreme strain of the failing heart and the lung clots are causing secondary myocardial muscle death. We call this a type 2 heart attack. Understanding the nuances of these markers paints the exact picture of what's happening inside his body, and it dictates the immediate treatments that will ultimately save his life.
We've covered the whole toolkit today. We explored the remarkable kinetics of troponin, the energy signals of CK, the pressure warnings of BNP, and the clot breakdown flags of D-dimer. It truly is a marvel of clinical enzymology. So I'll leave you with this provocative thought. If a single blood draw can unveil heart failure, active blood clots, and active heart muscle necrosis all at once, what invisible warning signs is your own blood carrying right now? Thanks for joining me on this deep dive. Keep learning, keep questioning, and I'll catch you on the next explainer.